very well of sir. You don't need to fly back. And he'll charge you for Indian travel. He got his training from Boston University and the University of Northern Carolina. He was previously an assistant professor at Nova Southeastern University in Florida and the implant program director at East Carolina University Dental School in North Carolina. He relocated to Mumbai and is now in full-time consulting and private practice. So that's a little introduction to our lovely Akshay.
Thank you so much.
And thank you, Akshay, for the last minute you accepted our invitation and you agreed. Before I give the floor to you, I refer Mr. Tushar, who's from Sensodyne, who has supported us for this program, to please formally welcome the guests here. Over to Tushar.
Good afternoon, doctors. Welcoming you on this wonderful session and wonderful lecture organized by IDA along with the GSK cooperation. So I welcome Akshay sir to give your lecture, and along with that, President Dr. Jeevan Shetty sir, and President-elect Dr. Afsan Lahiji, and past President Dr. Mahendra, and Shri Convener Dr. Ratin sir, who also taking my follow-up that when we are going to organize and how we are going to. So, and all the respected teachers along with Meshram sir and Dr. Kopati. So, welcoming you all with this on this session. So, do continue.
Thank you.
Your lecture, sir.
Thanks.
The floor is all yours.
Thank you.
Thank you.
Thank you so much for having me here. Again, IDA Mumbai branch goes a long way because I remember seeing a cutout in, I think it was the midday or the afternoon that time, when Dad got elected as the president of the IDA Mumbai branch, and this was in '94, if I'm not mistaken. And I had seen a small cutout. So since then, of course, IDA Mumbai branch has always held a special place. So thank you so much for inviting me, Jeevan and Dr. Das, for being a part of this, and I'm highly honored. The topic for today that I chose was implant aesthetics in the anterior zones. Now, I know a lot of us are doing implants, and we want to achieve that last bit where the patient walks out saying, "Oh, I'm really happy with the smile you gave me." So that is where I'm trying to bring it out in this presentation. Small tips, again, hopefully I should be done about an hour and 15 minutes to an hour and a half, so that all of you can get back to clinic, which is where I have to get back as well. So to start with, again, all cases shown in this presentation are done at our clinic or by me at various consultation clinics that I go for. Most procedures, if not all, are evidence-based, just that I haven't put the references in many of them. I have used various biomaterials for different cases, so all again purchased by us in the clinic. The main objectives for this lecture: factors resulting in a superior aesthetic outcome for anterior implants, immediate implant placement and its role in anterior aesthetics, handling the buccal peri-implant defect, which is at presentation, and unfortunately after many years, we see that at presentation it looks beautiful, but what goes on after the patient has not come back to us for many years, and when they come back, then they show up with a buccal defect. So what do we do in such a case? Also soft tissue for peri-implant defects, and finally papillae between implants. How do we make sure that we have that sharp papillae that we want between implants? So to start with, what are the main factors for an anterior implant aesthetic success? Now I want to show you some unaesthetic anterior implants. Again, you can see right here, something where the soft tissue has kind of gone north, where the implant has been placed a bit buccal, where you again see soft tissue with the abutment showing. Implants that are placed way buccal, where the emergence of the implant head is something where it cannot be restored, so the patient has gotten a fixed bridge based on teeth. And finally, a patient with a big smile line showing something where they either did not use pink porcelain, which could have brought it to a little better than what it is seen right now on the screen, But again, that is also a compromise. Anytime we use any kind of a pink ceramic, it is a compromise from what could have been ideal. So the first step in solving a problem is to recognize that it does exist. Unfortunately, what happens is many a times these are our own patients where we get an anesthetic result and we try to make it better by doing something or the other. We try to take some shortcuts to try to reach the end. And most often than not, we do not recognize that problem because guess what? We did that case ourselves. So we do not want to see that problem. Okay, we turn a blind eye to it and we said, okay, no, everything is fine. Just keep going. We'll manage it later as it comes. And that is where the problem starts. Once we start recognizing the problem, we can correct it right at the beginning rather than trying to solve it at the end. So recognizing the problem is very important. This is a classic paper by Dr. Wang, and he showed about management of the aesthetic outcome. It's a triangle or a pyramid, if you may call it so. We start at the top, which is the optical aesthetic. You, of course, need a good restorative work. Yeah, that's what it's not clear. Okay. Visible now? No, still a little bit. Okay, no worries, I'll read it out. Okay, so when we talk about this pyramid, at the base of the pyramid, we have space management. Okay, we have space management for preserving the soft and hard tissues, which involves socket augmentation, forced eruption, guided bone regeneration, and monocortical onlay graft. What does space management mean? At the time when the patient comes in for an extraction, you're already thinking about the implant. Okay. Now this is something which many of our patients may not agree with. Hey, doctor, pehle ye to nikal do, baad mein ka baad mein sochenge. But when they come baad mein, you've already lost tissue. So at that time, you have to take 2 steps back, try to regrow that bone, and then go back again and place an implant later. So instead of that, when you're doing the extraction itself, try to make it as atraumatic as possible. What is atraumatic extraction? Split the roots. Every single molar extraction, or for example, a first premolar extraction in our clinic done by me is by splitting the roots. It takes more time, okay, but it's well worth the effort. When you go forward and that patient comes in for an implant placement, you still have that bone present there to place that implant. So as much as possible, atraumatic extraction means split the roots and get them out separately. Socket augmentation, something that I used to do, I've kind of cut down on it. What it means is packing a bone graft as soon as you remove a tooth. Now that will add expense to your patient's budget, which again has to be explained to the patient about why it is important. And I agree with all of you when some of you may say that, you know what, not all my patients are ready to pay that extra bit right away. So which is another reason why I have shied away from doing socket augmentation. I used to be a big proponent of it, but I've shied away. But I also do explain to the patient. I say that you have to be ready for some amount of bone loss, which means you will have to be ready for some amount of bone augmentation or grafting at the time of implant placement. With that understanding, I'll go ahead, extract the tooth, not pack anything, leave it, come back and let me take a look as to what is happening. So that is the approach that I have been taking now, because again, we are all in the same boat where we don't want to give a huge figure to the patient right at the beginning and scare them away. Okay. Moving from there, we then go to hard tissue assessment, which again dictates the soft tissue and how it appears. Along with that, the papillae height appearance, the classic adage, bone sets the tone, tissue is the issue. Okay. If you have the bone, that will give you the tissue which is over it. So always ensure that you have a good amount of bone for your implant placement. You then move on to soft tissue assessment. You can use some soft tissue grafts. Thick and symmetric tissue is what you want. You can create an ovate site pontic. Let's say, for example, your patient does not want implants. Okay, he wants a bridge. But even in a bridge, you want to give him an aesthetic result. So start using temporary bridges. A good temporary bridge with a good soft tissue profile will help you in a long way in getting that final bridge with the soft tissue profile already created with the help of that temporary. Okay, so good temporization is very, very important, be it implant aesthetics or be it natural tooth aesthetics. Temporization is one aspect which I have always harped upon, which I was not very adept at when I started practicing. And once I went to the US and came back, Now, all teeth that come and get prepped get a temporary at the end of the first appointment. If in case this is an anterior zone, they get a chairside temporary first and a lab made temporary a few days later. So lab made temporary is essential for any kind of an anterior aesthetic restoration. And then finally, restorative, we can't do much without a good lab support. So always try to identify a good lab that can help you with your vision, because it always works that you have something, but if a lab does not match that vision, you're not getting anywhere. Okay, so always try to find a lab. If need be, call the lab owner to your clinic, sit him down, explain what your vision is, what kind of work you want, and that will go a long way in him understanding and then giving you the work that you expect. So always ensure that you have a good communication between yourself and your lab. Facial veneers, pink porcelain, and all of those, he can help you with that. So I come up with a 5-point criteria for anterior implant success. If implant aesthetics is right at the middle, the 5 prongs are: you want your hard tissue to be there, you want your soft tissue with a good biotype, you want a good 3-dimensional implant placement within the biologic zone. You cannot have an implant placed wherever you want or wherever the bone is and then expect an aesthetic result. That's not going to happen. Okay, you always have to get it in the right prosthetic position. Gone are the days when implant used to be a surgical specialty. Now it's completely prosthodontics driven. Okay, yes, thanks. I heard a clap there. So yes, yes, it is completely a prosthetic driven specialty. So you need to plan the end in mind and then start. You have to know where your crown is coming and then you will plan your implant placement. So it is a completely prosthetic driven specialty. Presence of adjacent tooth. Very, very important when you're thinking about anterior implant aesthetics. If in case there are 2 teeth, one of them can be saved with a root canal and the next tooth needs an implant, please go ahead and save that tooth with a root canal, because that is going to dictate how your papilla is going to form on the next tooth. And I'll show you some cases. And finally, temporization. I mentioned this again. I keep mentioning this. Very, very important. Even with your implants, please try and temporize. If in case it's an anterior, you cannot go forward without temporizing the case. That is going to give you a soft tissue profile. That is going to give you a vision of how your case will look at the end. So that in case you have to make any changes, it is going to be right at the start and not after 3 months when the implant is integrated and you can't do anything with it. Okay. Okay, so this is a slide. Again, I've put the link here. So for those of you here or online, you can go to this link. It is present online. So basically what it says is it's a flow chart about the way you need to go in any implant case. Of course, first would be medical and dental examinations, and the next would be a prosthetic treatment plan, followed by a keratinized tissue evaluation. I'm assuming we all know what keratinized tissue is. Okay, we want a good amount of keratinized tissue in all our implant cases, the minimum being 2 millimeters. So 2 millimeters of keratinized tissue is important. Once you have that, that is where the split comes about. You have adequate keratinized tissue, you have sufficient bone, go ahead and place your implant. You have insufficient bone, again it gets divided. You have a mild to moderate bone defect, bone augmentation plus implant at the same appointment. You have a severe bone defect, you have to bone augment first, come back a few months later and then place your implant. In case you have inadequate keratinized tissue, if you have sufficient bone, again you will do an STA, which is a soft tissue augmentation, followed by implant placement. Again, they're not done at the same time. You can see the flow chart. You can also place an implant and then do the soft tissue augmentation. You can do it together, which can be forcing Mother Nature a little bit too much. You're asking a lot of healing to take place right at that stage. Okay, so always try to stage it in a way that you get a good soft tissue profile, and then you can go ahead and place your implant. Now, the real issue comes when there is insufficient bone. Okay, and those are the majority of our patients, right? We are not blessed that we have patients walk in with tons of bone and tons of money. It's always one or the other. Okay, so when you have insufficient bone, then you have a whole lot of things that you can do. You can do soft tissue augmentation followed by bone augmentation followed by implant, or you do bone augmentation first, then soft tissue, then implant, bone augmentation, implant, and then soft tissue. So it's a permutation combination of all the three procedures. Okay, so always keep this handy so that you know which way the patient is going based on your keratinized tissue evaluation. Because long term, what's the role of keratinized tissue? It helps control the plaque from going any further down the implant hole. Okay, so anytime there is no keratinized tissue, it's a free open area for bacteria to go in. Keratinized tissue is your first line of defense. So that's the reason why it's very important. Okay, so this is a adage which was given to me by Dr. Garber, who practices with Dr. Salama in. Let me. Can I put the volume here, or will it? Yeah. Okay. Here are some examples of how the soft tissue can be molded. This was a patient who came in with an implant and a crown given about 6 years back, and recently came in saying the crown has dislodged. Look at the soft tissue profile. Because the crown was there, the soft tissue has taken the profile of the crown. So always ensure that your lab gives a good profile which can mold the soft tissue. If need be, give a temporary crown. A temporary acrylic crown will help you mold that soft tissue before you go to the final crown. These are just different instances of how the soft tissue looks. This is with the healing abutment and with the final abutment in place before the impression is made. Look at the soft tissue here. Nice papilla in between, right here. And a good amount of keratinized tissue. Of course, there was less. It could have been placed a little more palatally. But here I want to show you how nice and deep the papilla can be formed. So the papilla can take the shape of whatever you give. So here, this patient had temporary crowns, which is how that area has taken place. The shape has been taken place because of those temporary crowns. This is an implant placed deep with a huge healing abutment, narrow healing abutment. So that's why the soft tissue is like that. If in case it was wide, it would have been wider. So what is 3D placement of implant? 3D placement of implant is getting it again in the right prosthetic position. So here I'm placing a premolar implant, and you can see my implant head is coming on the buccal cusp of the lower, which, going back to our dental anatomy days, occlusion will tell you when you're in a class 1 occlusion, when you bite down, your central fossa of the upper goes on the buccal cusp of the lower, which is exactly where it is going, and that is in the right prosthetic position. Mesiodistally, you want it right in the center, and occlusally, you want it in a line which is in line with the central fossa of the premolar and between the incisal edge and the cingulum of the canal. So that is the ideal position. Once you're there, you know that the access hole of your implant is going right or coming out right where you want it, in a prosthetic position. Now, importance of adjacency. So we've spoken about the importance of hard tissue, soft tissue. We've spoken about the importance of having a good amount of the soft tissue profile. Here are some examples of implants placed next to adjacent natural teeth. So when I show you this image, this is one of the classic, which one is the tooth, which one is the implant, you know, that kind of a thing. This is what we need to achieve. Our end result should look like this, where we need to identify, the patient cannot identify which one is their tooth and which one is an implant. So in all these cases, one is an implant and one is a natural looking tooth. So we'll go through all of these cases as well. Now, most of the aesthetics that we saw can be achieved or will be achieved only if you go ahead and place your implant immediately. That is, extract and place the implant in the same appointment. about 80% of the cases in our clinic are immediately placed. And that's a strategic shift that has happened in the last few years, because more and more data and studies are coming which are showing that immediately placed implants go a long way in ensuring success, both aesthetically and functionally. Of course, when you place anterior implants, there is no other way. You have to try and place it immediately, as long as there is good bone and soft tissue present. And I'll show you cases where it was not possible and how we tackled that as well. So this is a case of a single tooth implant, immediate with temporization. This lady came in and she was missing her, or she was going to lose her two tooth. You can see a big fat post there. So for sure there was a fracture that was going to happen. So this was the tooth in question, tooth. So we extracted it atraumatically. Okay. Please go ahead and start using your luxators, periotomes. Oh, sorry. Just give me the chart. So this was a case where we extracted it. You can see immediately placed an implant. Temporary abutment is in place. And we give her a chair side temporary as soon as we are done. So that day she goes home like this and we don't see her for the next 3 months. Now, when we give this temporary crown, we ensure that it's completely free of all occlusal interferences, be it in maximum intercuspation or any lateral, and most importantly, no protrusive. The protrusive contact is the one that has to be completely eliminated in all anterior implant cases. So that is one thing that has to be kept in mind. So once we do that, finally she comes 3 months later, and that's the final abutment in place, and this is the final crown. How did we achieve this result? Because of immediately placing the implant, because of the depth of implant placement, which is very important. When I talk of the depth of implant placement, the implant neck will be 3 millimeters apical to your final CEJ of the implant crown. Now, if this is where I want my final crown to be, my implant is going to be 3 millimeters away from here. Remember I spoke about prosthetic planning? This is where it comes in. You are envisioning where your final crown would be. Now in her case, she already had a tooth. So I knew that this is where my soft tissue I want in my final restoration. So I placed my implant 3 millimeters deep. Why is that 3 millimeters important? That's the space for your abutment to come in. And also the classic biologic width that you want, your implant has to be away. So that will help form your papilla and give you a nice scallop. So all of that is taken care of by nature. As long as you place your implant in the right position, in the right depth, nature takes care of a lot of things. Okay. Another case, 40-year-old female. She came to us in May 2017, and look at this fracture. I have no idea what was being done here. I don't even know what kind of a post that is. Okay. So of course this was expected. So she had a fracture and she was going to lose this tooth. Now at this appointment itself, we told her that we would like to change the crown on this. We are thinking about aesthetics. Okay, this is how this was a preoperative smile. So we told her, we said, this is not a good looking crown and very difficult. And all of you would agree to match a single crown to something that is already present. Okay, no two ceramic blocks are the same and no two technicians are the same. So you'll always have variation. So we said it's easier for us to match both of them. So allow us to change this as well. She was adamant, no, I just want this to be taken care of. So we said, fine, we can do that. There's a smile, a very pretty looking woman, but again, she didn't want. And the other thing is, you can observe that this was supraerupted. 1-1 was a little supraerupted. So we explained that as well to her. But you know how some patients are, they're like, no, do not touch that. I said, okay, fine. So we went ahead and just started taking care of the tooth which is next to it. As atraumatic as it can be with a fractured tooth, we all know that it cannot be very atraumatic. Okay, so we got the tooth out, placed the implant. In the space between the implant and the bone, I packed some bone graft, which is called the jumping distance. I packed some bone graft. I have also shied away from packing that because if I have a good 2 millimeters of bone, buccal bone left, I leave it. I leave that empty space. Nature takes care of it. Only when that buccal bone is thinner, then I try to pack some bone graft in there. So this is how she came, and these are the X-rays. So we placed an implant right there. We put a healing abutment and we gave her a flipper. We gave her a removable partial denture, and of course she disappeared. 1.5 years she didn't come back because she was an out-of-station patient. And then finally, this was in October 2019, she came back to us. This is a flipper, a removable partial denture, and the next tooth is still like that. At this stage, she comes in and she says, you know what, I think now I'm ready. I said, thank God, you realized it before we gave the crown on the next tooth. Okay, so we said, okay, good. So we'll get this changed as well, and we'll give you your implant crown. This is how it looked. We had left her with a healing abutment. Now, many a times, temporization may not be possible for whatever reason. Then please choose a good healing abutment which has the profile of your final crown. And there are many that are available with the companies. Companies are lazy. They'll give you the trident, the ones that everyone says, and they'll say, oh, everyone uses this. And they are like bottle shape, just straight up and down. No, you want something that has an emergence profile. So hound the company. Every company has it. Okay, they have it in their stocks. You have to tell them that you want that. What are these healing abutments? Basically, what they do is they kind of go in this way. They are wider at the top, and then they narrow down as they reach the implant. So you want something like that. Now, because we had a good wide healing abutment, you see, this is how an ideal healing abutment should look like. So you're mimicking your natural prosthesis. So we took an impression and we gave her a crown and we replaced the crown, and this is the final delivery. Look at the papilla that we could achieve only because there was natural teeth available on both sides, and the depth of implant placement was where we wanted it to be. Now, some of us may think, oh, but the zenith is different. Doesn't matter. Why? Because this is how she started. This is the middle. This is at the end. Look at her smile. Okay. Now, when she smiles, this is how she came into us. Look at her smile. With a full smile, also she's not showing any of those. Now, if we had to push, okay, and this I probably would have done it when I started my implant journey, I would have pushed for an implant on the next tooth. Okay, I would have pushed for an implant in 1-1 saying, you know what, this is going to fail in the next few years. Let's get it up. And I'll place 2 implants. And what would I have got? That papilla would have gone up. Very difficult to get papilla between 2 implants. Now, wiser sense has prevailed. Doing less is more. Okay, and which I, again, sure all the seniors would agree here. As you keep practicing more and more, you do less and less, because that gives you more success. Okay, and I've learned that now from my dad, because I used to be when I came back from the US, I'm like, oh, I'll do this, I'll do that. I'm like, no. He was like, take a step back, do what is required, and later on you'll see why I'm saying that. And now I've started realizing that. And now when I tell my son that, of course, the tables have turned. Okay, so I'm realizing how difficult it is to be a father now. Right? Too early. Too early. I still have a long way to go. I know. Okay, so yeah, that is one thing that I have learned. Doing less is more. So now I preserve whatever is possible. Later on, when she comes with an issue in that tooth, I can always replace that and try to give her what best is there. So I'm not trying to predict the future, because many a times we have done that and we have failed. She didn't come with that issue. She didn't come with that. I was pushing her. I would have pushed her for that implant also, and then realized that it would have been worse than what she ended up with. Okay. So what's the secret? Again, atraumatic extraction, immediate implants, temporization. All 3 very important to achieve a good aesthetic result. Now, this is just a video of how from atraumatic extractions in the clinic. So luxators and elevators to good effect right here. One hand on the buccal bone to ensure that it's not being fractured. Try to loosen up as much as possible. The forceps are going to be used only to deliver the tooth out, nothing else. Okay, and of course, no buccal movement, it's just rotation. And once we do that, we immediately place an implant. We all know that with immediate implants, your implant has to go as palatal as possible, kissing the palatal bone. So we drive the implant in to about 3 millimeters below where we want it to. Same thing with the other sides as well. And always remember, whenever you place immediate implants, always keep your hand on the buccal and palatal, because anytime you go either ways, you'll know that you're trying to perforate. So you can then redirect your placement. Okay. So these are the implants that are placed. This is the temporary. Now, how do we do this temporary? What we do in our clinic is whenever patients come in for an immediate implant or for implants per se, in case we have to give them temporary, we tell them that we are going to make an impression on that day. We send it to the lab and thank our stars that we live in Bombay where we have good access to labs, because I've seen my colleagues in tier 2 cities struggle with getting these because the labs are not there. So they have to send it to Bombay and they're like, oh, I'm struggling to get these parts. And so every time I thank my stars that we are here and we are lucky to be here with good lab support. So we make an impression, I send it to the lab and the lab gives it to me in about 2 to 3 days. That timeline has now shortened because now we have a scanner. I immediately scan it. The lab has already received it. Next day evening, I have it in my clinic. And on day 3 morning, if I do the surgery on day 1, on day 3 morning, I already am giving it to, or day 2 evening, I'm already delivering the temporaries in their mouth. So the timeline has shortened a lot now. Previously, it used to take about 3-4 days for the lab to turn their temporaries. And I used to be a little itchy about going back later after 4 days of placing implant, trying to remove the healing compartment and putting the temporary. Now that time has shortened. Okay, so I give a lab temporary. It is always a screw retained temporary made up of PMMA. It is always will have an access hole. Okay, because this is the temporary. So I explain to the patient that we are going to take care of your aesthetics with the final crown. With temporary, all I'm trying to do is get the soft tissue profile in order, get you some teeth so that you can present yourself out. But please don't ask about the aesthetic aspect of it, the color match, everything, we'll do it when we give you the final crown. Okay. These are the implants placed. And this is how they will look. So these are implants that are done, and then screw retained temporaries, acrylic, PMMA, which is why you don't see it on the X-ray. Now, what does the evidence show? Again, I can keep showing you cases that, you know, this works, this works, this works. But studies are one thing which will show you exactly that it just does not work in my hands or just does not work in Bombay. It should work everywhere around the world. Okay. So with immediate provisionalization and soft tissue, there was an average increase in tissue height of 1 millimeter for immediately provisionally restored implants following their placement in fresh extraction sites. I have seen cases where I placed the implant and I'm like, okay, my soft tissue is looking nice, and I've gone back and I've actually gained soft tissue. Okay, and that has happened. So, which is good because you can always take that off whenever you're doing your final restoration. But gaining soft tissue is something that each of us should be blessed with. When we do it, we are assured that we will gain some amount of soft tissue. So that is one evidence to show that immediate implants are the way to go. 2.5 to 3 times less mid-facial recession and better predictability of papilla heights in the immediately provisionally restored group. Okay. One thing I want to make it clear, when I'm talking about provisionalization, again, I'm ensuring that my contacts are all free. Okay. It is not immediate loading. Immediate loading is a completely different thing. I am immediately temporizing it. You probably can immediately load when you're doing a full mouth implant prosthesis, but with single units or a few units, immediate temporization without any occlusion. What about inter-implant distance, contact point, and soft tissue? Your optimum inter-implant distance between two implants was greater than 2 millimeters, but less than 4 millimeters. Now, why is this? So that we can get a good papilla. Okay, so that we can get a good papilla. Right there in between the two implants. So you can see right here, I'm delivering the temporary prosthesis in this patient, and I have some amount of papilla that is going to be there and it will remain there Because remember that slide I showed you about how the soft tissue takes the shape of whatever I put, it's going to remain right where it is. Optimum bone to contact height should be about 3 to 4 millimeters, so that the papilla height decreased when this distance exceeded 6 millimeters. So again, in that slide right there, the distance between the bone between those two implants and the contact point should be 3 to 4 millimeters. If in case it increases, you're going to end up with a flat papilla. If it's more than 4 millimeters, the soft tissue is going to flatten out. So always try to make sure that your distance between the contact point and the bone is about 3 to 4 millimeters. Many times when it's not possible, your lab has to give you good support by trying to give a large contact area. Okay, instead of a contact point, he has to give you a large contact area. So that is something that many of us have to teach our labs, because a lot of them have come into this without any formal training. Our labs guys have come into it without formal training, so they are expecting us to teach them, and we have to take on that role. So please ensure that you call that lab guy and explain to him what you're expecting. So this is the same case, and you can see the nice papilla that has been formed right here. A good depth of placement. This is the metal trial stage, and this is the final restoration. And you can see right here between the natural tooth and the implant tooth, you can see a nice sharp papilla. Same thing on the other side. And this will give you an idea. This is an implant right here, and this is an implant right here. So you see how flat the papilla is? Coming back to my point about how difficult it is to grow a papilla between two implants. 6 months later, same thing. Of course, she can do a much better job of trying to keep the area clean, but the papilla is still where it should be. And 1 year later also, we have a similar outcome. Now, this is all rosy when everything goes according to plan. But what's plan B? What if none of these work? If there is no primary stability, you have no choice but to graft that area and come back later. Okay? You have to have a good primary stability for immediately placed implants if you are going to give a temporization. You cannot temporize with implants that do not have primary stability. Now, if you want a number associated with that primary stability, it has to be above 35 Newton centimeters. Okay? Above 35 NCM is when you can comfortably go and give a provision restoration on your implants. Anything below that, just put a cover screw and leave it, or a healing compartment and leave it. Don't load it. Exposed buccal threads or thin buccal wall with a good primary stability, you can graft and temporize. Why am I saying temporize here? Because you have got good primary stability. All you have are some exposed threads on the buccal, which you can graft. And remember, nothing's going to happen to it as long as you clear them of all occlusal interferences. Primary stability less than 40, as I mentioned, submerge, and you can temporize later. Okay, so always after 3 months of implant healing, you can still go to a temporary phase. You can still give temporary restoration to the patient, check it out in their mouth for at least about a month or month and a half, and then move that on to a final restoration. And when you give that temporary restoration, please make sure the patient pays the entire amount. Okay, otherwise the patient will be happy to just leave your practice and go with the temporary and live on with it. And we actually have a patient like that who probably is now in her 6th year of an anterior implant with a temporary crown, and she's not come back. So always make sure you take the final payment before you start with any kind of restoration. Okay.
Don't do good provision.
Yeah, that is another. Don't do good provision. Exactly. Or make it many shades darker than actual.
I have a cardiologist, he's so busy with the surgery, so many hospitals, he still not gone back.
Right, that's what I say. We have, all of us will have such patients, who will not come back because you've given them a temporary. So I've had this question at many other forums as well. They're like, doc, but the patient doesn't come back if I give temporary. I said, take the money beforehand. Take the money when you're giving the temporary, and then later on, when they come for, they will come back for, because the money is with you, they will come back. Okay, so handling the buccal defect, and these are 2 cases that I want to show you. One will be at presentation, and one years later when the patient comes back. So this is a congenitally missing lateral incisor in a patient, young female. I think she was 22. The orthodontics was done by your last speaker, Dr. Vishal Dhanjani. I believe he spoke last. So he, I believe, is the one who recommended me. So again, I told thanks to Vishal first. So this was a case that was done by him. So he finished the orthodontics. We discussed the case before, and I said, you know what, I need some more space here, because if you look at the X-ray here, this was of course post the CBCT, but this root right here was positioned towards each other. So there was no place for my implant. So I asked him to kind of straighten the teeth out, top them straight, and then I have my place. So this was post ortho. So you can see in the previous image, she had some amount of diastema and all. So he ended up correcting all of that, and he opened up the space and gave it to me. So we got a CBCT, and when I look at the CBCT here, I see a thin coronal bone, and I see a nice wide apex. That gives me the confidence that I can place my implant with a good primary stability, and I can try and give a temporary restoration. If not, at least I can get my implant in place and graft it. Okay, I may give her a, she already had a temporary flipper, so she was probably going to go back on it. The only thing I need to make sure was that the flipper would not touch my grafted area. So the flange had to be completely taken off. So this is where we started the surgery. So you can see right here, this is her smile. I give my papilla sparing incision. So you can see I have not touched the papilla there. Okay, I have gone away from the papilla. And once I give my papilla sparing incisions, I start reflecting the flap, and you can see how thin the bone is there. Now, this is a bone scraper. Anytime I do my augmentation, I need some amount of natural autogenous bone, because that is going to give my growth factors. Okay, so I scrape bone. I then use my densa burrs to try and get whatever expansion I can a little bit in that area. I collect whatever bone has been there with my osteotomy, and I go ahead and I place my implant. So see, while the implant is going in, also it's taking away bone, because this is in the right prosthetic position, but I still have my primary stability because of good apical bone. So I collect all that bone. I do what is called as decortication. I use a very small round burr, and you can see how I just go through the. You can see that periosteal releasing engine. I check my passivity. The flap has to be passive. And then I first layer is the bone that I collected, autogens, right on the threads. Okay, so I place those, and over that I place my allograft or xenograft, whichever bone graft you have. The first layer is very important, which has to be an autograft. Over that, you can place a long resorbing xenograft or allograft in that area. You can see here, this is a xenograft that I'm placing. Bulk it up more than you need it, because there will always be resorption. And I place a collagen membrane over it. Once I place my collagen membrane, I give what is called as a horizontal mattress suture. So I have gone through the buccal, gone through the lingual. I again enter through the palatal aspect of the flap, take it out, and then re-enter through the inner aspect of the buccal flap. So that is my horizontal mattress suture. The main idea behind this suturing, I need to take tension away from the edges of the flap. Okay, so you see, once I do this, the edges of my flap are free of tension, so then I can just approximate it and give some intraoperative sutures. Here I'm closing my vertical. So once I've done that, this is still her flipper in place. She has a temporary. This is the healing ointment, and look at this right here. Look at this papilla that has been formed. Again, only because of the depth of placement being accurate and ensuring that there's a good buccal bulk that was given. So you can see this buccal bulk that has formed. She didn't have that before.
So you push with the original.
Yes, we push Yeah. So here with this, but even with a temporary abutment, we push it more than we want it. So that will ensure that there's a good amount of. But now when you push with that provision, please make sure the blanching does not last more than 15 minutes. If it lasts more than 15 minutes, you're strangulating the tissue, which is not good. Which means you need to take the temporary out, lessen it, okay, trim it more, then try to push it again. Okay, so blanching is very important, but not more than 15 minutes. And this is how her final looks. This is another case where we had some thread exposure. I'm just showing you this case, even though this is a posterior case, I'm just showing you how I manage such cases where there is thread exposure. Okay, so at presentation. So this was a case where we placed an implant, but it was failing. So I gave a vertical incision, and you can see the buccal, there is soft tissue encapsulation, and the implant was failing. So we took it out, cleaned the area. Okay, so we had thorough debridement of the socket. And luckily she had bone apically, so we went ahead and placed a longer implant in that same area. Okay, so right there. Now buccal threads are exposed. So I packed some bone graft in that area, and I used what is called as an O6 Volumax membrane. And this forms a kind of a place it in there, and again my horizontal matrix sutures, a good periosteal releasing incision, and get a good passivity of the flap to ensure primary closure. So this is at 2 weeks. I could see some of the membrane peeking out. I just snipped it off, and you can see right here, I can see some of the implant head. This is before, and this is after, and you can see this bulk that has been created. You can see that at 4 months. So this is where I want to show you about how, remember we saw the neck of the implant? Look at what has happened here. The soft tissue has grown over the implant head. Okay. Your tissue always has an ability which is called as creeping attachment. What is creeping attachment? Over time, your tissue creeps up more than where you saw it before. Okay. So this is exactly what has happened here, is creeping attachment. So you can see here as well, the neck of the implant could be seen, and now it is submerged within the soft tissue. Right here. You can appreciate this. Okay. And this was the final delivery. You can see right here. And this is how the bulk looks. So this is not going to go anywhere. That bulk is going to stay, and that implant is protected. So very important to augment bone when you have less buccal bone. Either at the time of implant placement, or if it's too much of bulking that you have to do, then before implant placement and then later on come and place the implant. This is a 10-month post-op of the same case, and you can see the bulk being maintained right here. Another case where I use the same membrane, and this is an anterior case. This is how the patient looked initially. Okay, so we planned to place 5 implants right here. Now 6 months later, I could place only 4 implants. I did not get good primary stability, so I grafted that site. When I took the CBCT, my 2-3 implant, that is this implant right here, you can see that it's kind of outside the bony housing. Why is it there? Because that was the right ideal prosthetic position. Okay, so I got my implant in the right ideal prosthetic position, but when I see this on the CBCT, I cannot leave it like that. I need to do something. Luckily, I was going to go back to place this implant, so it gave me an opportunity to correct that. Okay, now this is of the neighboring side where I grafted it, so you can see I've got a good bulk. So I go ahead and I placed my implant. So this is the video of the, you can see my graft particles are still there. Okay, that's very common with xenograft particles, especially hydroxyapatite crystals. When you see, you're going to see that. So I'm placing my implant, which I could not place at the initial period. I got good primary stability. I drive it in. And once I drive it in, I take the same R6 Volumax that I used in the previous case, and I place it right over that area. Now, what I've used here is what a small tip which all of you can use is it is an impression post. Okay, it's a close stay impression post. It can help you in getting your sutures around it, and then you remove it and place your healing abutment. So that way your tissue does not close completely when you're suturing. Okay. Also, you can use an impression post to help you with parallelism of your implants. Okay, so always surgically keep your impression post along with you so that you can place it after you place one implant. Use that impression post to gain your parallelism on the next implant. So I always use that, and it's been helping in making sure we get good parallel placements. So this is how it looked. Now see what I did here. The implant where I had kind of put the Volumax, I primarily closed it. I'm not going to take a risk. She can still get a temporary on the others because the others were integrated. So I gave her a temporary connecting all the others, and I put a healing abutment on this after 3 months. And this is how it looks. And this is a flipped image, so you can see this is actually the image, and you can see right here. That's the healing abutment of the implant where I placed it, and that is my access hole. So in the right prosthetic position where I want it. So many times when you place your implant in the right prosthetic position, it may end up being outside the bony housing. So please be aware of that. Please keep your hand on the buckle to know where you're placing the implant. And this is her smile. And in the final restoration, we'll correct it. She's right on temporary, so we'll probably get this fang-looking canine a little rounded and get her in shape. Hot topic, socket shield. Okay, I have also dabbled in it. I am not a big proponent or user of it, but I pick and choose my cases. I pick and choose where I need to do it. And this was a case which I felt. Now, for those who are uninitiated to this, what does it mean? Basically, the buccal bone blood supply is through the periodontal ligament fibers. We all know that. So that's your buccal bone right there. And those are your periodontal ligament fibers. So the blood supply is through that. Now, extraction leads to loss of the blood supply to the buccal bone. When you extract, you're losing those PDL fibers, so the blood supply is gone. When the blood supply is gone, this buccal bone is also gone. What does this technique ensure? It's basically trying to fool the body into thinking that there is a good amount of buccal bone still present right here. Just use this. Right here. It's fooling the body, saying, okay, you know what, there's some amount of tooth still there, so the buccal bone just be there. So it's trying to fool it. So we extract everything else, but a small sliver of tooth is left behind. So this was a patient, 38-year-old from another town. Problem this was she wanted her diastema closed. She wanted to correct her proclination, and majorly she was losing her 1-1. Why was she losing her 1-1? I'll just show it to you. So we took an alginate, a putty impression before we even started. And this was a procedure. Okay, so this was a preoperative view. And you can look at, it was separated right here at the neck. So she was, we had to extract that tooth. Split the tooth, mesiodistally. Okay, right here. And tease out the parietal part. And this is where you have to be a little lucky. Okay, so only with luxators and periotomes. And you can see that I've taken the apex out and I've left a small sliver of the buccal in the mouth. And then I go ahead and prepare the shield. I make it thin enough so that there is a good amount of space. There's no contact between the shield and the implant. Once I do that, I go ahead and place my implant in the right prosthetic position again. And this is the implant going in. So I've used a wide 4.1 implant because she had a good amount of bone. So So once my implant is placed, I check to make sure the implant is about 3 millimeters away from the gingival margin, and I put the temporary abutment in place. Now, once I put my temporary abutment in place, I mark as to where until I need to cut it. So right there, there's a marking. And I take an X-ray to check the fit. And I cut it in place. Remember, I had a impression beforehand, so I pack my temporary material into it, take it into her mouth, create an access hole from the lingual where it was. So even before I do this, I pack that temporary abutment with Teflon. And this is how I take it out in one piece, and then I try to finish it. So I've joined them here, and this is how the temporary crown looks. Okay. So this is how it looks. This is on the lingual. I packed Teflon tape, and this is the X-ray. Before starting the surgery, this is how she looked. And 2 hours later, this is how she looked. Now, at this stage, remember my access hole is on the lingual, but her issue is she's still not happy with the proclination. Okay, she says, I came with the proclination, you're still giving me the proclination. I said, hold it. We will correct that at the final stage. Right now, this is a temporary. Okay, so in the end, what will happen? My access hole will probably move a little bit buckle, which means I may have to go with the cemented restoration, which is still okay, but at least I can get a good aesthetic result, or I can get what she wants. Now, coming to the economics of immediate temporization, this is one thing that I keep getting asked, like, how expensive is it? Why should I do it? Why am I spending my time and money on it? Okay, let's compare. You have a chair side provisional. I'm assuming time taken would be about 15 to 20 minutes. Your time taken for chair side temporization, 30 to 45 minutes for me, probably 5 to 10 minutes for Dr. Das. Okay, and for all the prosthodontists in the room. I'm not a prosthodontist. I still take time to do a good temporization with a block. I learned how to do a block temp, but it still takes a good amount of time. Okay. Costs involved, your temporary material, your temporary abutment, and the most important, chair time. Okay. One of the most important things which we realize later on is how chair time affects everything that you do. Let's take it on the other side. Time taken for placing an implant, again 15 to 20 minutes. Time taken for an impression, 5 minutes. Lab charges for a PMMA temporary, approximately rupees 800, okay, which is what my lab charges me, along with, you have to send a temporary abutment, or if they can source it, then well and good, they'll charge you for that. Time taken for delivering the temporary crown, 15 to 20 minutes after 2 days. So you're not spending this amount of time at the same time when a patient is waiting for you outside your next appointment. So place the implant, make an impression, send it to the lab, call the patient 2 days later, and then deliver it. So that way you can even do a follow-up on your patient, and along with that, give them a temporary crown. So it makes complete economic sense along with the timing aspect of it. So same case, time to restore, about 4 months later, this is how it looks. Okay, this is nice, soft tissue. The implant is placed deep. It has taken the shape of my temporary, and this is how I want my final to look. So this is how it looks. I capture the soft tissue with some composite flow with my impression post in place. That's my impression post. And finally, I go with the titanium abutment. Titanium abutment and a zirconia crown. This is in place, and of course she gets a crown on the next tooth as well, and we close that astig. So you can see right here how we have tried to create that papilla in between the implants, and again only because of the depth of placement, and in this case because we have the socket shield, you can see the buccal bulk that we have, and that will be maintained. Now, what if that shield fails later on? I probably will have to take the shield out, and I may end up losing some of it, but we'll see how long it lasts. Which is why I said I do not use it in every single case. I pick and choose the cases where the patient is also agreeable. That is something which I tell my patients beforehand, that what I'm doing is something that is novel, something that studies are coming up, which may become mainstream in the near future, but currently it is not. So would you allow me to leave a piece of your tooth inside? If the patient says okay, then I proceed with it. And this is how her smile looks. And we have a natural emergence profile. Looks as if the tooth is coming out of the gingiva as it ideally should. And this is a side view. And you can see the buccal bulk that we have achieved right here. And these are cemented crowns. The final X-ray. So, coming to tissue remodeling in immediate versus delayed prosthetic restoration, especially when done in fresh extraction sockets. There were two in this study. Okay, it was a 4-year follow-up of 30 implants with immediate loading approach and 30 implants with loading 3 months post-healing. It showed that the immediate implants restored on the day of surgery demonstrated more stable soft tissue and bone volume maintenance. So any study that you pick up, it will show you that there is stable soft tissue volumes with bone volumes maintained over time when you immediately place an implant and immediately provisionalize it. So hopefully after this lecture today, I hope most of you who do implants will start looking at cases with the intent of immediately placing them and immediately giving them a temporary restoration. Now, what about abutment based on gingival thickness? You saw in that last case, I showed you 2 cases where I used a zirconia abutment in that young girl who had lost a lateral, and I used a titanium abutment in this last case. So how do I pick and choose what to use where? The natural gingival color was not reproduced with any abutment with gingiva thinner than 2 millimeters. Which means you need to know what your tissue biotype is. You need to know what kind of a tissue thickness you're dealing with before choosing your abutment. Gone are the days when you used to call the lab, "Arey haan, tumhe jo pasand hai wo use karo yaar." You know, or the lab guy will tell you, "Sir, aapko jo karna karo, main apne aapko karke deta hu. Aap chinta mat karo, aap jo chahe use karo." Later on, you cannot blame it in front of the patient. You can't blame the lab because you have taken responsibility. Okay, so check the tissue biotype, check how thick or thin it is, and based on that, you can choose your abutment. So the natural color was not reproduced with any abutment with gingiva that is thin. The worst color match was with titanium abutments, and the best was with fluorescent zirconia followed by VCA4 shaded zirconia. So the best color match is with zirconia abutments, but when you actually have a thick soft tissue, which is thicker than 2 millimeters, it doesn't matter. You can use zirconia, you can use titanium, you can use anything. So your tissue biotype will determine. Okay, so no differences between abutments when the thickness was greater than 2 millimeters. Now, peri-implant tissues decades later. Now, this was a case that dad did, and she got her implants done, I believe, 2002 or 3. Yeah, 2002 or 3. And she was, at that time, 14 or 15. She lost her front tooth. Okay, she lost her central incisors, that is 2-1 and 2-2. So at that time, remember, there were no, this was 2002 or 3, when there were no studies about age being a factor in implant placement. Okay. Later on, it came about saying, oh, you cannot place implants until the growth is over. So this patient got her implants. Dad placed it in 2002, both of the 2-1 and 2-2. So she is now 35, 36. Yeah. So she's 35, 36. She comes in. She stays in Dubai. She comes in and she's a fashion designer. Now she's, of course, more into the world now that the masks have come out. She's like, okay, I need something done because I'm not too happy with the way, wait for it, not this, with the way this looks. Okay. She's like, I'm not too happy, but I'm only giving you 1.5 weeks to work on it. So we told her, okay, this is a very short time, but we'll try our best, but be assured that there may be some amount of inflammation that you'll end up going back with. Okay. Because we are not getting enough time for a follow-up. At this point of time, she also said, I'm not happy with this area right here because food gets stuck there. Remember, your buccally, when we think about our area, it's all a self-cleansing area, right? It gets washed off. But here, she actually has a defect. Over the years, the buccal bone has resolved. So whenever she eats, she's like, my food gets stuck there. Can we do something about it? So this is when we said, okay, we need a treatment plan. So this was her problem list. Of course, her smile, Okay, she's like, I want it better. I'm not happy that here I don't see any of the gums and here I see gums. Do we extract and place an implant on this tooth, which is this one, which she's not happy about, or do we leave it? Gingival zeniths, as I mentioned, is different. Diastema between 1-1 and 1-2, which she's not happy about. Implant health, these are the implants that were placed in 2002, still solid, some amount of bone loss. Do we go and be aggressive and get these 2 implants out, graft and place it? Or do we say, okay, let's see how we can manage it from here on, and later on we can do that. Remember, she's 35, okay? She still probably has another 50 years to live, hopefully. So we need to think about that aspect. Many a times in our implant planning, we are thinking very short term. We are thinking, how will it look in the next 1 year? What we are not thinking is that patient is going to lose that tooth and have that implant, and we need to service that implant for the rest of their lives. So again, the dictum is, I try to save teeth as much as possible and place implant when that is not possible. Hard and soft tissue defect above 2-2, which I mentioned. Altered passive eruption. Remember, these implants were placed when she was 13 or 14. Over time, her teeth have erupted more. There's a concept of altered passive eruption that has taken place, which is your teeth will keep on erupting as you progress in life. And because of your occlusion, it is kept in the same position. So you can, if you compare it, these teeth, 1-1 and 1-2, have some altered passive eruption. So we need to take care of that as well. And finally, time. She's giving us only 1.5 weeks. Okay. So this was our treatment plan. On this visit, day 1, Thursday, remove the crown on 1-1 and evaluate. If salvageable, a full coverage restoration on 1-1 and a veneer on 1-2 with crown length. Remember the gingival zeniths? If non-salvageable, immediate implant and a temporary crown. Day 2, Friday, augment the buccal defect on 2-2. Soft tissue only, soft and hard tissue, or hard tissue only. I'll come to know only once I open the flap. Then I give her PMMA temporaries on 1-1 and 1-2. Weekend, nothing can be done. Day 4, Monday, temporary crown on 1-1 and temporary veneer on 1-2. Day 6, Wednesday, final cementation of anterior crown and veneer. And finally, day 8, Friday, final follow-up before the patient flies off. So we presented this plan to her and we told her about all these question marks based on what we see. And she's like, okay, let's go ahead with it. So we took a shade first before we even began. And we removed the crown, and all the restorative work here was done by my wife, Aparna here. We did a soft tissue crown lengthening. Remember, there was no time to open it up and take off the bone, which is how ideally it should have been done. And I opened up that soft tissue defect on her 2 implants. So what I did was, I gave a vertical incision. My main aim was to try and protect the papilla between those 2 implants. Whatever little papilla was there, I wanted to protect. So I did what is called as a tunneling technique. I tunneled with my Organ's knife. So right here, I accessed that implant. Once I accessed it, I felt the threads. When I felt the threads, I had no other option but to open the flap. Because now that I know that the threads are exposed, that the buccal bone is gone, I need to augment it. So I access the complete area and I open it up, and this is the threads. So an implant placed 20 years back, I open it and the buccal bone is lost. And this is the reality of most of our implants that you will see 20 years later. Okay, that buccal bone is going to keep resolving as time progresses. The only thing that will help you is a good, thick, soft tissue. So I augmented the site just similar to what I showed you in that other case, made decortications around the implant, placed my bone graft, placed a membrane, and closed it. And we took a shade match for the other side, and we delivered, and this is when we delivered the crown and the veneer, and we closed up that side. And this was the before and the after. Okay, so her main concern of her smile was taken care of. Her main concern of the irregular zenith was taken care of. Of these teeth looking longer was taken care of. The only thing is we told her that expect some inflammation on that because we did a soft tissue crown lengthening. The bone was much closer. 3 months later, of course, she has this inflammation. She sent me a picture from there. She's like, hey, when I come there next, let's see how we can correct it. And I told her that we need to change these crowns on those implants as well. Okay, but you can see the bulk that she's got, and you can see the papilla is still maintained. And she'll come back when next time you've told her to keep 2 weeks. We need to change the crowns on those implants and make a decision. So I wanted to show this just to show how we approach a case like this in terms of treatment planning it before we jump into doing things. Now, what about soft tissue? Again, as I said, this is the most common thing that you will see if you have been in practice in implant dentistry for a long time. You'll keep seeing this. You will see these defects right at the middle third of the implants. So how do you tackle these? Open that area up, push it and close it. And you can see, you can buy some more time. Now, this was a case where ideally should have been grafted. The patient was not ready for it. No, I don't want to graft. I don't want to spend that money. Okay, I'll go and take your own soft tissue and I'll put it there. And we'll buy some more time. Okay, a good thick soft tissue will stay there for a long time. This was a girl that came in during my residency, 22-year-old, again, congenitally missing laterals. So you can see she's wearing a removable partial denture. And she said, I never got my permanent teeth and I want something fixed there. So this is how she looked. And again, everyone comes with a timeline. Okay, I'm getting married in 1 year. So I want everything done within 1 year. Nobody comes with a lot of time in their hand. Okay, everyone is busy. So this is the internal examination. This is how it looks. There's some spacing right here, but the orthodontist was like, I'm done because the patient did not want to continue ortho any further. So we said, okay, fine. Now, this is an assessment table that I use before every implant case. It's called the SAC assessment, Simple Advanced Complex Case, which is brought about by the ITI. You can Google it, SAC assessment by ITI. And it tells you aesthetic risk factors, low, medium, and high. So if I take this case, medical status, healthy patient, intact immune system, works in our favor. Smoking habit, non-smoker, again works in our favor. Patient's aesthetic evaluation, of course it is high because she's getting married. Lip line, medium lip line, so that works in our favor also. Gingival biotype is medium, scalloped, and medium thick. Okay, so it's not very thin, neither is it too thick. Shape of the tooth crowns are rectangular. Is there any infection in the implant site? There's no infection. Bone level at the adjacent teeth, very close to the contact point where we want it. Restorative status of neighboring teeth, virgin teeth. Width of the original span, 1 tooth. And the soft tissue anatomy is intact soft tissue. So the more lows you get, highly successful the cases. The more highs you get, make sure you charge your patient more because there are more headaches. Okay, with time, and again, as I said, I keep learning all these practice management tips from my father. So he's like, with time, there are more headaches in a case, make sure you charge more. Okay, because you're spending that much of effort, your mind is constantly on that case, you need to be compensated for that. So I I was lucky to attend Dr. Shankarayya's lecture last week when he had come to Bombay, and he said one very good thing on it, right? So he said that with time, stop charging your patients on a per implant basis. Start charging for your time, which is so true. He said, if you're placing multiple implants, don't think about, oh, per implant I'm charging this much, am I making that much money? Because guess what? If one implant fails, your entire process fails, all that calculation goes out of the window. Rather, he says, charge for your time, maybe place an extra implant, and maybe that 10,000 of that implant that you're going is going to bring you peace of mind, because if one fails next to it, you still have that implant to save you. So with time, and I still have to learn that. I have not come to that position yet, but it was a very unique thing which I heard, and I said it makes so much sense, because we should be charging for our time, which is how, if you go to a lawyer, they're not charging you per case, they're charging you for your time. Right? So we as professionals have to think in that direction. Let's start charging for our time and not per. A lot of people, what do? They break down the implant treatment cost, saying this is for my implant placement, this is for my implant, this is for my temporary. No, give them a round figure. Because when you give them breakdown, they're going to go to 10 other places and find out what that breakdown is. Whereas if you give them a full figure, they will not have that opportunity. If they ask you for a breakdown, you know that they're going shopping. You know they have gone somewhere who has given them that breakdown. So start charging your implant patients as a whole amount, saying, for me to give you a tooth in this region, this would be my amount. It will go a long way in ensuring that you are covered for any mishaps later on, any failures, you're covered because you are taking more than what is required. So this case, I sent it for a wax up. Okay, so this is the wax up that I sent to the lab. So I know where my ideal implant position is. I take a CT scan and I plan for my implant right here. This is the surgery. I open up the site. Now remember, anytime you open a virgin tooth site, remember your bone is flat. You have to create that scalloping. Your teeth are not flat. Your crowns are not flat. Okay, so you have to create that scalloping. How will you create the scalloping? You will have a stent ready based on that wax up. You know where your final crown is going to be. Your scalloping will be 3 millimeters away from there. You will leave the bone interproximally where it is, but you will take away bone in the midfacial region. Once you scallop it, you have your final position. Your implant will come right where it has to be. Your implant neck will rest right in that 3 millimeter zone. Do it on both sides. That's my direction indicator. And finally, I have my implants placed. She had a good looking temporary, so I give it back to her. 3 months later, she comes in and she says, Doc, she pulls her lip out. What is this gray zone? And my heart sinks. I said, okay, what have I done here? I should have grafted it. I took the shorter route of placing the implant without. And this is how it looks. And if we gave her some veneers because she wanted the diastema closed, these are some apartments. This was the impression. Now, what you saw there, these are temporary apartments in place. These are the final zirconia apartments. Okay. We've already discussed this in terms of zirconia apartments being, they have shown they have less increase in BOP, that is bleeding on probing over time, and zirconia apartments had less plaque accumulation over time. Okay. And finally, this is how she looked. So you can see the nice papilla that we got in between. So when I was talking to you about how in the case of the anterior fracture, you saw how we got nice deep papilla, whereas in this case, we got the papilla a little shallower, but look at the contact area. It's not a contact point, it's a contact area. So these are the nuances that your lab has to work with in conjunction with you in knowing where they need to give a contact area and where they need to give a contact point. Okay. And this is how she looked before she left. And these are the post-restoration radiographs. So sometimes things don't work out the way we want them to. For example, this case here, this lady came in and she was not too happy with her lateral incisor. This was a lateral incisor which she had been working to save for years and years. We tried grafting, we tried everything, and it just didn't work. So finally we said, okay, we need to get that tooth out and maybe give you an implant. Now the plan was to orthodontically extrude this so that I get the bone down with it, place an implant so that the soft tissue and the bone come down, and then get an aesthetic result. So we did that. We did a slow extrusion over 3 months, and you can see the bone levels here, right here. So if I compare the bone levels, you see where we started with, which was a vertical bone defect, and look at how it has become a horizontal bone defect as we extruded the tooth. Okay, so now I got the bone down, because remember, the further the bone here, the longer the tooth looks. Okay, so I need to bring it as much lower or coronally as possible. So I extracted the tooth after it came to a level where the tooth was mobile. After ortho, we removed it. I did a soft tissue grafting there to get this area. Closed it up. And this is the soft tissue grafting, and she wore her denture. She had a removable partial denture. 2 months later, this is how it looked. Now at this stage, she was adamant she wanted her treatment finished soon. Whereas I wanted to wait, because tissue maturation takes time. Soft tissue maturation takes anywhere from 4 to 6 months before you can go ahead and do anything. So I wanted to wait, and she said, no, doc, I need it, I really need it. So I said, okay, fine. So I had this, I went ahead and placed the implant, and look where my implant had to end up. Because I did not get a good soft tissue profile, I did not get good primary stability, so I had to make sure my implant was placed deep. So all the work that I did or had planned came to nothing, but she was still happy because she got a tooth. But in the mind of, let's say, a perfectionist who wants everything, who had planned everything beforehand, saying, I want this, 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 sometimes things don't work. And we have to accept that. We have to accept the fact that there are sometimes things won't work, but as long as the patient is happy, you should be okay. So we did get some papilla here. I wanted this soft tissue profile somewhere here. But again, this is something that I live with and that she will live with too. This is where she started with, and this is where she ended up. Now, if you think about aesthetics in the posterior region, papillae between implants, again, same thing. Depth of placement and positioning of the implants between each other is very important in getting a good papillae between implants. So if you think about this, okay, all 3 implants, look at the nice sharp papillae between an implant and a tooth. Remember, coming back to my point about saving a natural tooth. Because my depth of implant was good enough, I'm getting somewhat of a semblance of a papillae between the 2 implants, right here and here. And somewhat of an papillae right here as well. Papillae are important not just for aesthetics, but also for having a good self-cleansing area. Okay. So right here, it's about 3.5 millimeters and about 4.5 millimeters here. So the depth of implant placement matters here as well. Healing power of the gingiva. We've seen so much of soft tissue, but it is so forgiving. This case right here, I placed the implant. Okay, buccal bones, buccal threads were exposed. So I grafted that site. I closed it up. One of the major things that I did not achieve here is passive primary closure. You can see there's a lot of tension on the flap, which means the flap is going to open up, which is what happened. The flap opened up. I can see my implant peeking through here, my sutures, my bone graft. At this stage, what do? I ask the patient to go on a chlorhexidine rinse. They are going to do a chlorhexidine rinse, at least for the first 2 weeks after this happens. Post that, they're going to take a Q-tip, earbud, dip it in chlorhexidine, and gently rub in that area for the next 2 months, every single day, at least 2 or 3 times. What is that doing? It's going to prevent any infection in the site. Am I going to lose bone that I grafted? Of course I will, because it's opened up. But am I going to help the soft tissue heal? Yes, because this is how it looked later on. Nature, when given the right environment, is going to help you, but it needs the right environment. Okay, so we got some amount of bone still left, and we went ahead and restored it later. And this is how they still do gold crowns in the US. Pretty expensive here, but gold has stood the test of time. I mean, even now, when I used to see these patients and I used to ask them, when did you get these crowns done? Oh, it's been about 40 years. And beautiful looking gold crowns. So gold has stood the test of time. Okay, so that's in occlusion. So, what is my take-home message? Immediate implant whenever possible. Mold the tissues with immediate temporaries and keep them out of occlusion. Okay, I call them molding the pink to enhance the white. Okay, you are molding the pink so that your white gets enhanced. Build up the hard tissue and it will give you a good soft tissue as well. Best aesthetics is between an implant and a natural tooth. Depth of placement, very, very important. Okay, please have the final prosthetic position in mind when you're thinking about depth of placement. Give the tissue time to heal. We are all rushing. Okay, now I always get asked this question: do you do immediate molars? I say I do, but it probably is 1 out of 100 because there's no urgency. If the patient has teeth in the front, they are able to chew well. They can live with getting an implant after 3 months and getting a crown after 3 months. There is no way that I would rush into doing anything because my primary stability is important and I may not be able to get that primary stability. So I'm going to shy away from doing that. Unless I have a good fat interdental bone, then yes, I'll anchor it right there. But I'm not, iffy cases, 50-50 cases, I'm not even taking a chance. I extract the tooth, let it heal, go ahead and place an implant, and let the patient know I'll see you 6 months down the line, you'll have a crown in place. And save natural teeth. And that is the periodontist in me speaking. Okay? Because as you go ahead, as you keep moving forward in your career, you'll keep finding that natural teeth are the ones that will stay in the mouth longer. Once you extract the natural teeth, your titanium is not going to stay there lifelong and will keep replacing titanium. Okay? So try as much as possible to save natural teeth. When push comes to shove and not possible, only then go for implants. Thank you very much for being a very good audience. And of course, it's tough. I know post-lunch is always a tough being, trying to stay awake. But thank you so much for being a lovely audience. Again, this is the contact details. If any of you want to contact us, that's my email address, periofamily@gmail.com. We are on Instagram on periofamily. So just follow us there. And I try to post my cases there as well as on YouTube. I have a channel. You can just YouTube Dr. Akshay Kumarswamy, and many of these cases videos are there on YouTube as well. Thank you so much.
Thank you, Akshay, for this lovely presentation. I must say, you so beautifully played with the slides, and I'm sure kept all of us awake even after that rabdi and gulab jamun. And some questions.
Any questions? Yeah.
Questions? Give me the lights.
What's your take on the use of water flossers?
Good. So use of water flossers. So I do recommend using a water flosser. I tell my patients, but I also tell them it is not a substitute for actual flossing. Okay? Because what a water flosser does is take away the loose debris, but interproximally it's not going to take away. So interproximally, they still have to use a good amount of the regular wax floss, but water flossers are good, especially for implant patients. And in fact, we were just talking about this day before. We are trying to institute a thing where, for full mouth cases, we want to add a water flosser into the treatment and then give it. So that, yeah, exactly. So we were a little late in doing this, so I just talking about that aspect, and
They like it if you tell them it's free of cost.
exactly. And you factor in the cost. You don't need to tell them that it is correct. So it's not much. So factor in a water flosser.
Is there a minimal optimal pressure that has to be standing on is
I know. So again, each person's gingiva is different. Each person's pressure that they can handle is different. But I would say somewhere around a 5 is good. Yeah. Any other questions? Yes.
Yeah.
So what I mean about socket we have one surface which is in contact with the tooth. So that part is actually a dead space which is not also integrated. Like you want pads.
So again, see, the histology also is very not clear on this. Okay. So I have seen that what they want to in the histology they have shown is there is some amount of fibrous tissue that grows between the shield and the implant surface. Okay. There's no bone that is growing in. So, which is the reason why they say thin the socket out as much as possible, hoping that bone will grow there. I still have to see histology where there's actual bone that has grown between the shield and the implant. So that is the one thing. But yes, which is why I am not a big user of socket shield. I pick and choose my cases. In the last 4 years, I probably have done only 10 cases of socket shield. In that, 2 of them failed, where the implant failed because the shield failed, and most of the others worked. So yeah, I don't do it much.
Do you place bone graft in between the jumping distance every time?
No, in between you're talking about socket shield or regular cases? No, I don't. I just leave it there. I let the blood fill in that area.
There was some bone graft in place.
No, there's no bone graft in that socket shield case, no. But in the case where I used to do immediate implants previously, I used to pack bone graft. I stopped doing that also. I stopped doing that also. I let nature take care of it. As long as the buccal bone is 2 millimeters or
Any more questions?
yeah, Roxa brush very important. I mean, so incidental brushes. Every patient nowadays, I don't know if any of you work with dent care lab. They send you a Roxa brush, okay, which is good. Which is good because I don't remember to give it to my patient, so they send it to you. But yes, every patient. Now, even when you give a Roxa brush, please let them know that there are two sizes, narrow and wide, and they should not push it. Okay, it's only when it easily goes through and through is when they should be using it. Now, how will the patient know? You can take a probe and see interproximally if your probe passes through. If your probe passes through, then the brush will pass. So tell the patient that, okay, this is an area where you can use a narrow space interdental brush, or if they have wide space, then a wide space interdental brush. But a very good device that most of our patients should have.
Yeah.
Yes.
What's your view on a single apartment or a one-time apartment concept?
Okay, so in order to get a one-time apartment, your placement has to be so accurate. That is one thing with your depth of placement and everything. If you have all of those in order, then you can. And we have done that also, where even for a temporary restoration, the apartment that I've given is a final apartment, but I've given a temporary crown. So works well because what the main concept where it came from is the fact that every time you put an abutment, okay, and you remove it, your soft tissue hemidesmosable attachment is opening up. Okay, so that will constantly open up and close, and it may cause some recession. So to prevent that, give a final abutment and then work whatever you want to on the top of it. So yeah, it's a wonderful concept, which but only if your placement is in the ideal position.
So we have also movement because abutment, like single piece and that like or it's movement.
Right.
So I don't know how.
So that is the one which looks like a basal implant but is not.
It's not
Right? Yeah, I have not ventured into those because in my hand, doing the single implant with an abutment, like a single piece, is very tough because you have to get that so accurate, the positioning. And even after doing thousands of implants, I don't think I can still get my accuracy in place. So I would rather have a two-piece where I place it and then I can correct it later on with my abutment.
And now only about the temporary apartment that you were talking about. What is the time frame that you look at? See, 2 days you said. So up to how long do you think that we go ahead and
Good. So we have done it about a week in time as well, but beyond a week we have not. We have then again labs have turned the rest now. So I don't want to risk.
Sometimes the labs just don't
give it exactly. So I do not want to risk that. So only if okay, that is one other important point. Whenever you do an immediate implant case, please inform your lab beforehand that you are sending an immediate implant case. Okay, keep your lab ready.
stand by.
Stand by. They need to know that they're going to receive a case from you, which needs to be returned soon. Only then will they work towards it. You cannot surprise them after you have placed the implant. Sir, बहुत काम है. Then they won't send you the case.
Never do it on a weekend.
Exactly. Never do it on the weekend. Yes. Okay. Or if you want to do it on the weekend, do it on a Friday, so the lab has time to work on a Saturday and still can send it to you on a Monday morning. Okay. So communication between you and the lab, very, very important at every step in an implant case.
Any more questions? So thank you so much.
Great.
For
Thank you.
It was a wonderful time.
Thank you.
Listening to you. And I now request our very senior person, Dr. Suresh Mishram sir, to please come ahead and felicitate our speaker for the day. I request our president to also join us.
Very good, Akshay.
Thank you so much, sir.
Very nice. Chief of the
Thank you.
Yeah, you speak very well. Thank you. Very well, yeah.
One.
Thank you so much.
Thank you for the opportunity.
So I got it was absolutely younger Kumarswamy sir speaking with much more knowledge and with added information and refurbished information. I would say refurbished information. You know, if we would put Kumarswamy sir on a reboot mode and a fresh one has come out. That's what it is. I'm sorry, but I'll keep comparing it with that.
Thank you. No, I just keep telling, and the thing is, I of course am lucky that I have a son, and the things that I'm
You're the
learning.
lucky Abhishek Bachchan.
I know.
I know what you're the lucky Abhishek Bachchan, but
You know what I'm learning now, as I mentioned, is what I learned in residency was everything very ideal. You know, array study had shown this, studies had shown this, but private practice is completely a different ballgame.
Absolutely.
Where, as I said, you have to do less to ensure that things work. So I'm learning that aspect of it now, working with dad,
Especially again in India, things are
correct, exactly. So as I said, I keep telling that to all my audiences, saying doing less is more.
And you said the same thing, like you said practice and teaching now. I feel teaching when I was in college was different. It was very ideal. Now I'm teaching more realistic things to my students who come to me for my courses. You know, so that's teaching is also different.
Very true.
Things are different. Thank you so much.
Thank you so much.
Thank you, Aparna, for joining us. And I think so. Before we call,
letting him speak today.
I know. Letting you speak exactly.
For a long time.
And before we call off, I'll request Mr. Tushar to introduce us with all the Sensodyne products. Please, you were given due time. Over to you, Tushar.
Thank you. So thank you for giving me time. I will not take much of your time. So our product portfolio is very simple. Entire Sensodyne range according to your patient requirement. You can choose out from. One is Sensodyne Repair and Protect. This comes with Noamine sodium fluoride combination, specially designed for the chronic dentin hypersensitivity patient, where we want to provide the long-term protection like maintenance for the long term. And other is Sensodyne Rapid Relief. Whenever you are looking out for immediate relief like chair-side patient application, comes with strontium acetate sodium fluoride combination, 9-10 ppm. So after crown cutting scaling, where you want to provide the immediate relief to your patient, then you can consider our Sensodyne Rapid Relief. Along with this sensitivity patient, in your day-to-day practice, you are also seeing gum disease patient very frequently, because many of the patients are unaware of having gum disease, and 3 out of 1 patient having gum disease. So do consider our Parodontax gum care toothpaste. This comes with 67% of sodium bicarbonate. This is our new launch product. So requesting for your support, doctor. As the basic mode of action of our Parodontax is, it penetrates deep inside the plaque biofilm, make the plaque biofilm soft, so it can be easily removed via daily brushing. So that's the basic mode of action. And we had also done some studies on our Parodontax, like Joe Settle Aquagyre Metal, which shows that Parodontax effectively reduces the overall bleeding sites by 58%, and also the plaque rebuilt up in between the 2 mechanical cleaning. Also, the plaque built up when patient do not maintain their oral hygiene. So that effectively reduces up to 56%. So do consider, doctor. But whenever you prescribe, tell your patient that this toothpaste will be little bit salty, so patient will not become hyper that कैसा toothpaste दिया डॉक्टर साहब ने नमकीन वाला ये क्या देती है तो ऐसा बोल सकते हैं सर आप और लास्टली जो डेंचर एडिसिव के डेंचर वेयरिंग पेशेंट्स होते हैं सर उनको जो डेंचर पे प्राइमरीली फर्स्टली शिफ्ट हो जाते हैं तो उनको प्रॉब्लम होता है कि कितना भी अच्छा डेंचर ऑब्वियसली आप अच्छा डेंचर बनाते हैं लेकिन कैसा होता है कि कुछ भी ऐसी नई चीज ऐसी मुंह में आ जाती है तो पेशेंट को पहले एक थोड़ा सा बोलते हैं ना एक आदत होने तक थोड़ा सा हाँ तो उसके वजह से मैम ये पॉलीडेंट है ये तो मैं डॉक्टर्स को बताता हूँ तो डॉक्टर मुझे बोलते हैं यार तुम्हारा ये लगाएंगे तो हमारे प्रैक्टिस का मतलब क्या है इतना पढ़ने की तो फिर भी मैं बोलता हूँ कि कैसा है मैम नए पेशेंट जो शिफ्ट होते हैं तो वो पेशेंट के लिए कंफर्ट फील कराने के लिए कुछ नया चीज का तो पॉलीडेंट है ये 12 आवर का स्ट्रॉन्ग होल्ड देता है सर एंड इसमें देयर इज नो जिंक एडेड नो कलर नो फ्लेवर तो मैम पेशेंट को ऐसा लगाने के बाद भी लगेगा नहीं कि कुछ मैंने डेंचर पे अप्लाई किया और जो मोस्टली जो जेरियाट्रिक पेशेंट होते हैं जो कि जिंक टैबलेट्स भी लेते हैं मल्टीविटामिन में जिंक भी होता है तो ये भी यूज करेंगे और वो जिंक टैबलेट भी लेंगे तो जिंक का ओवरडोज होने का चांसेस होता है जो कि एडीए ने भी कहा है कि मतलब एडिसिव शुड नॉट हैव जिंक तो वो भी जिंक भी नहीं है, कलर नहीं है, फ्लेवर नहीं है, और 12 आवर का मोस्टली स्ट्रॉन्ग होल्ड है। कोई भी इंडिया में अभी तक, जैसे मुझे डॉक्टर से फीडबैक मिला कि इंडिया में अभी तक ऐसा होल्ड उनको ज्यादा से ज्यादा 4 से 5 घंटे का मिला है, और हमारे प्रोडक्ट जो डॉक्टर्स ने यूज किया उनको अराउंड 8 घंटे का होल्ड मिला है, 8 घंटे का मिला।
So this can be put over soft tissue liners also.
No. You don't need this soft tissue lining. Once you give a soft tissue lining, it itself acts.
सर बस पेशेंट को सर ऐसा ही बोल दीजिएगा कि जो डेंचर है उनका, बाकी जो डेंचर एडेसिव वो लोग बोलते हैं कि गीला होना चाहिए, लेकिन हमारे केस में डेंचर एकदम ड्राई होना चाहिए, तो जितना ड्राई होगा उतना अच्छा ही एडिशन करेगा। तो ये सारे हमारे प्रोडक्ट्स हैं सर। सो थैंक यू फॉर लिसनिंग एंड थैंक यू फॉर गिविंग मी टाइम।
I now request our President-elect, Dr. Akshay, to please deliver the vote.
Good evening, everybody. First of all, we would like to thank Almighty for this first offline session more than 2 years, right? Secondly, I would love to present my sincere gratitude and thanks to Dr. Akshay for a lovely presentation, for a good explanation, for lovely pictures, and thank you very much for sharing the lovely videos with us.
Thanks.
On behalf of Indian Dental Association, we thank GSK, especially Mr. Tushar Kadam, for very good coordination between the company, the director, the IDA, Dr. Das, and the hotel management. Thank you very much. My sincere thanks and gratitude on behalf of Indian Dental Association.
It's an honor for me now to getting the meeting with IDA. So ये मेरा भी थोड़ा सा फायदा ही है ना।
I thank our President, Dr. Jivan Shetty, and Dr. Rajesh Gaikwad, our Honorary Secretary, for prompt action for making this a good program. And a special thanks to Dr. Ratin Das sir, because he was coordinating so well with the participation of the people, coordinating with Tushar and with me and with everybody. My sincere thanks to our teachers and our pillars of IDA, Dr. Mishram sir, Dr. Kokate sir, Dr. Sharif sir, and I'm missing Dr. Lucia sir and Paul sir. Lastly, I thank all the other people from GSK, Mr. Tushar, Mr. Raju, and Aishwarya madam. Thank you very much for all your coordination. I thank all the lovely audience. And at the end, I would like to wish Dr. Maisha for her birthday. I wish you all. And all the people who are really cooperated and come here, especially Dr. Parveen and Dr. Shanawaz. Where is Dr. Shanawaz? Yeah. And Dr. Sharif, in spite of their rosa, they are here with us. Thank you very much. And a lovely audience. Thank you, ma'am. Thank you very much. She's just come back from this early morning. She's arrived and she's with us here. So everybody on the young generation, my sincere thanks. Next year when I'm president, I have promised him that we should have a session with him. Lastly, I would like to thank Aparna madam, without which otherwise there would have been incompletion of the lecture, because she noticed that the battery is getting over. Thank you very much. All of us can join us for tea, coffee. Yeah. Yes, I'm so sorry. My sincere thanks for Dr. Neil. Last time also he coordinated very well for our previous lecture on dentistry of pure art, and now also thanks a lot. And now all of you can join us for tea. Thank you.
Thank you.